A 22-year-old man undergoing intensive induction chemotherapy for acute leukemia presents with bloody diarrhea, severe right lower quadrant abdominal pain, and profound neutropenia. I am showing you an axial contrast-enhanced CT of the abdomen. Describe the findings.
Okay. The CT demonstrates diffuse, marked, and asymmetric mural thickening that is specifically localized to the cecum and ascending colon. The thickened bowel wall exhibits intense mucosal hyperenhancement, surrounded by extensive submucosal edema, producing a prominent target sign.
Are there any significant extraluminal findings associated with the colonic thickening?
Okay. Yes, there is prominent, hazy inflammatory fat stranding radiating deeply into the adjacent right pericolonic space, indicating a severe acute inflammatory process extending beyond the serosa.
Given the patient's profoundly immunocompromised state, what are the two primary differential diagnoses for severe, right-sided acute colitis?
In a profoundly neutropenic or immunosuppressed patient, the primary considerations for severe right-sided colitis are neutropenic colitis, also known as typhlitis, and an opportunistic viral infection, most classically cytomegalovirus or CMV colitis.
If this is indeed CMV colitis, what specific vascular complication does the virus cause locally within the bowel wall?
The CMV virus actively invades and infects the vascular endothelial cells within the colonic submucosa. This leads to a severe localized vasculitis, which results in focal ischemic necrosis, deep ulceration, and a remarkably high risk of spontaneous bowel perforation.
How does the typical anatomic distribution of pseudomembranous colitis differ from typical typhlitis or CMV colitis on a CT scan?
So, pseudomembranous colitis typically presents as a diffuse pancolitis involving the entirety of the large bowel. In sharp contrast, typhlitis and early CMV colitis have a very strong predilection for the right hemicolon, specifically centering on and aggressively involving the cecum.
If this were typhlitis, what would be the defining pathological mechanism?
Typhlitis results from a complete loss of mucosal integrity due to extreme neutropenia, which allows normal bowel flora to aggressively invade the compromised bowel wall, leading to rapid transmural necrosis and sepsis.
How would you initially manage this patient as a radiologist?
Well, this is a precarious clinical situation. I would urgently communicate the findings of severe right-sided colitis to the primary oncology and infectious disease teams, emphasizing the high risk of impending perforation.
What specific diagnostic procedure is required to definitively distinguish between a viral etiology and neutropenic enterocolitis?
I would recommend immediate stool sampling and a careful flexible sigmoidoscopy or limited colonoscopy with biopsies. Tissue pathology is required to definitively identify CMV inclusion bodies versus simple neutropenic necrosis, which is critical for initiating the correct targeted antimicrobial therapies.